welcome everyone to our third journal club for the year. So before we start, I'd like to acknowledge the traditional custodian of the lands on which we are meeting today. So I'm on Camarago land, so 65,000 years of culture, one of the oldest one in the world. So I'd like to pay my respect to the elders, past, present, emerging, and acknowledge their deep connections to land, sea, and sky. So today's journal club is from the Princess Alexandra team in Brisbane with 2 presentations. So each one will go for about 20 minutes, and then we'll have discussion at the end of each consultation. And also like to remind everyone about the next 2 journal club, one in August and one at the end of the year on the 5th of November. The ANZSA ASM is on 10 to 11 of October in Hobart. The invited speaker is a clinician scientist, Professor Joseph Houston from Emory Medical School. And then July is the Sarcoma Awareness Month. And this year, ANZSA is holding the first formal fundraising activity, plankathon. So get your team together, try to plank for an hour or however way you like. So I'll hand over to David to introduce the 2 speakers.
Thank you. I'll just share screen. So yeah, my name's David Pryor. I'm a radiation oncologist. Just trying to get this working, sorry, at the PA hospital. And then we also have one of the advanced trainees, Dr. Zulkifli, who's a medical oncology registrar, who'll be talking on the second one. I'm just going to share my screen. Can you see that?
Yeah,
screen?
We can see it. Yeah.
Yep. So the first article is one I saw last month about whole abdominal radiotherapy. Now, I have to admit up front that I don't do pediatric oncology, and so my experience with this is very, very slim, if not nothing. But I was quite interested to read about it and also hear about perhaps other people's practices, and also from the pediatric AYA side. But this is basically a Canadian sarcoma research, clinical and collaboration study looking at whole abdominal radiotherapy. In the title, they say it's tolerable and effective in children and young adults with intra-abdominal sarcoma. I was used to learning about it in Wilms and neuroblastoma, but haven't used it much in sarcoma. And this was a case that had come through our MDT previously that I'd remembered from the AYA side. It was a 17-year-old boy who'd presented with quite diffuse peritoneal deposits on CT. As you can see there, no extra abdominal disease, and at laparoscopy had multiple peritoneal, omental, cystic masses in the pelvis. And the biopsy showed small round blue cells with this fusion consistent with desmoplastic small round cell tumour. He had VAC-IE, and I understand the plan was to get him to as good a response as possible. Ended up being about 10 cycles in total with minimal radiological disease, but did have significant delays due to COVID at the time and flu infections. Proceeded to cytoreductive surgery and HIPEC, where they did find some residual nodules of tumour, and then completed 14 cycles of chemo and has been disease-free. So those kind of 2, one, the case, and 2, some of these more recent presentations just prompted having a look at this in a bit more detail. Retroperitoneal sarcomas, obviously we more commonly see them in adults, typically liposarcomas, leiomyosarcomas. In children and young adults, the intra-abdominal sarcomas can be more along the Ewing sarcoma, rhabdo, fibrosarcoma, or the desmoplastic small round cell tumours. I'm used to, as I said, hearing during my training about using very low dose abdominal RT for Wilms tumour. And obviously we can't give typical sarcoma doses in the order of 45 to 65 gray.
10, 15, 16.
Sorry, there's someone talking. Everyone can mute.
Someone's counting cells.
Counting the dose of radiation to the abdomen.
Yeah, that's right. Stop there. Stop. Yeah, so those type of typical sarcoma doses can't be delivered without toxicity becoming a significant limiting factor. The doses I saw range from 24 to 30 gray, with the option to give boosts to residual. And then also the increasing use of cytoreductive surgery and HIPEC, particularly for desmoplastic small round cell tumours. But there is limited data on this, and both on efficacy and toxicity. So that's why they looked at the Canadian sarcoma database, or their national registry. So in terms of the actual recent paper itself, it was only small, despite it being a nationwide registry, obviously very rare scenarios. But in terms of the indication, they had 20 patients, median age was 14 years, and the majority of them were the desmoplastic small round cell tumours or rhabdomyosarcomas, a smattering of other histologies. All of them obviously had the Ewing style chemotherapy, and majority of them received whole abdominal radiation as part of the initial therapy, so not as salvage. And indications included peritoneal deposits, malignant ascites, and I think there was a couple of cases of tumour spill. Majority of those received whole abdominal radiotherapy after achieving no evidence of disease. 3 of them received whole abdominal radiation following a relapse, and this cohort expectedly fared pretty poorly. And then in this particular cohort, 4 patients had whole abdominal radiotherapy after cytoreductive surgery and HIPEC. So small cohort, but predominantly upfront therapy, and with the desmoplastic small round cell tumours, whole abdominal radiation after chemo, surgery, HIPEC. In terms of the efficacy, on the right is the incidence of abdominal progression, and the red lines the salvage, so they fared poorly. So I think the 3 patients who received it for recurrent disease pretty quickly relapsed. But overall, abdominal recurrences after using whole abdominal radiotherapy as part of the multimodal treatment in the frontline setting were only in the order of 20%. 5 patients had some residual disease at the time of whole abdominal radiotherapy, with only 1 infield relapse. No patient with rhabdomyosarcoma had an infield recurrence. And the 2-year progression-free survival was 80% for rhabdomyosarcoma and 50% for desmoplastic small round cell. And as I said, 4 of the patients with the desmoplastic small round cell received cytoreductive surgery and HIPEC, and none of those patients had intra-abdominal recurrence, or, according to the authors, any acute or chronic toxicity greater than grade 3, at least as documented in the registry. Other supporting studies, they did cite a French study which took a retrospective look at patients with desmoplastic small round cell tumour, and they reported a median PFS of 22 months for those who had whole abdominal radiation versus 8.6 months for those that had more focal radiotherapy. And then there was also an MD Anderson study reported a little while back on 32 patients with desmoplastic small round cell, half of whom had metastatic disease at diagnosis. They all had, again, the Ewing style chemotherapy until complete or plateaued response, and no evidence of extra abdominal pelvic disease. They all had cytoreductive surgery and HIPEC with a median time from diagnosis to surgery in the order of 8 months. And then a median of 1.5 months later, whole abdominal radiotherapy to 30 gray in 20 fractions, and mostly concurrent with their remaining chemotherapy. And they reported similarly low rate of abdominal disease progression, so 16%, and a median survival of 60 months. Toxicity-wise, in the current registry study, they said only 3 patients developed grade 3 acute toxicity, and they listed that as diarrhea or renal failure. None of those patients had acute toxicity following the HIPEC and whole abdominal radiotherapy, apparently. And all of the acute toxicity had resolved by 3 months following whole abdominal radiotherapy, with no late kidney, liver, or GI toxicity reported. 2 patients developed second malignancies. One was ALL pretty soon after therapy, and then another was bladder cancer 11 years after therapy, which is a more consistent timeline for a radiation-induced malignancy. But they note that both had alkylating agents and that they didn't have any info on cancer predisposition. In terms of other studies, though, the Memorial Sloan Kettering reported on 21 patients, and they did say there was a high incidence of high-grade toxicity. So there was about a third who developed small bowel obstruction. That was reported back in 2002. Admittedly, they did use older radiation techniques in higher doses where you can get some hotspots, so significantly higher doses in bowel where you didn't think you were. But the more recent MD Anderson study looking at it in combination with cytoreductive surgery and HIPEC, they reported 40% grade 4 toxicity. A lot of it hematological, but it did include small bowel obstruction, intestinal fibrosis as late effects. And they did have 2 patients die of acute liver failure, which was veno-occlusive disease, which is what we can see with radiation-induced liver failure. So there's a few dissenting studies in terms of toxicity. This is just an idea of a slight difference these days. So on the left of screen, the target for this was the abdominopelvic cavity, and they've shielded out the central liver and central renal parenchyma. And then we tell the treatment planning algorithms to drive the dose out of them to reduce the risk of kidney or liver damage. In the middle, some isodose lines showing a fairly rudimentary translation of that with cooler dose within the parenchyma of the liver, and then also cooler doses around the spine and the left kidney. And then similarly on the right panel. So obviously significant limitations here. It's a very small retrospective series, very heterogeneous population of lots of tumour types and different treatment patterns, and very limited follow-up data within the registry. They're not prospectively, comprehensively documenting this like some of the phase 2 trials that I mentioned, or some of the other institutional series. And so acute toxicity and late effects are likely heavily underreported. So in terms of summary, the authors concluded that whole abdominal radiation at these doses is well tolerated, including after HIPEC. Although, as I said, other series from Memorial and MD Anderson suggest there's a higher risk of significant toxicity. They note that abdominal control rates are promising when used in the upfront setting, although overall outcomes for desmoplastic small round cell tumour still remain poor. And then they concluded that whole abdominal radiotherapy should remain an important component of controlling these aggressive malignancies, following discussion with patients and families about potential long-term toxicities, including second malignancies. So from my end, reading through that literature, I'm still a little bit unsure about where the role lies, particularly in adult sarcoma presentations. I'd certainly be interested in hearing from the rest of the team in terms of their practice patterns and thoughts on it.
Thanks, David. Are there any questions at all for David or comments about the use of whole abdominal wall radiotherapy in sarcoma?
Is it something that you've used, Angela?
Look, a handful of time for desmoplastic small round cell tumor, whole abdominal, the young adults. I don't do pediatric cases. I tend to limit to those with proven peritoneal disease and with no metastatic disease, and they've gone through chemotherapy, HIPEC, maximal resection, survive, and is doing well, good performance status, then I would treat. There's really only a handful. They do get quite nauseated with radiotherapy, acute toxicity, despite all the pre-med.
Yeah, I'd find it hard to believe that there's not a reasonable amount of acute and late toxicity with whole abdominal. Has anyone else had any experience with it?
Peter Mac, is there something? Oh, Viv, you had a hand up?
Oh yeah, so I think mine and your cases are, I mean, we're talking about the same cases. I think when it comes to DSRCT, I'm always really pleased if you can actually get your patients to a state where you could even consider whole abdominal radiotherapy, because the number of patients who get to that stage, limited to abdominal disease, good response to chemotherapy, then undergo successful cytoreductive surgery and HIPEC, and are still alive in good performance status. So you filter out those patients step by step along the way. But if they get to whole abdominal, if they get to even a consideration of whole abdominal radiotherapy, I'm very happy, because these are the only, I think it is an important modality if you are ever entertaining the possibility of some longer term survival for these patients. And yes, there's acute toxicities, as Angela and you have described, but I think they're generally quite manageable. And if they get to experience the long-term toxicities, and if they were diagnosed with DSRCT, then we'll just deal with them down the track.
Great, thank you. Jeremy, what's the Peter Mac experience?
Yeah, I think Viv has probably summarised this actually quite nicely, that I'm less concerned around the long-term toxicities if we have patients with DSRCT who can kind of get to it. Most of our patients, unfortunately, have extra-abdominal disease and really haven't had sort of the right patient where we thought that would specifically be of value. But, there's a law of attrition, I guess, in DSRCT, that they just fall off so quickly. And so it's just, with our patient, but we really haven't used, I mean, maybe I can think in our whole 5 to 10 years, maybe we've used it once or so, but we really just haven't had that sort of patient who sits in that sweet spot where we think it'd be valuable. But it's interesting that the Canadian group seem to be using it quite a lot more. I don't know whether that's patient selection, but nevertheless, interesting data.
Do we have any pediatric oncologists online to make a comment? Toby and Marianne, what's the usual practice in pediatric sarcoma?
I haven't had to treat kids with DSRCT, but certainly used whole abdomen radiation therapy and rhabdomyosarcoma. Doses would be similar to what's described. Again, often concurrently with chemotherapy. They're pretty rare patients, often will tolerate it. In Wilms tumor, again, whole abdomen is often used for kids with rupture. And again, lower dose, generally well tolerated. Probably the chemotherapy is much less aggressive though. We wouldn't use a lot of whole abdomen radiation therapy, but it certainly comes up mainly in sort of solid tumors.
Great, thank you.
So David, just a quick question. That case you presented, so that case happened during COVID. Patient still alive, as far as you know?
Yes.
Well, there you go. That's the whole abdominal radiotherapy.
It wasn't during the initial COVID. I think it was last year.
Oh, okay.
No, sorry.
I thought if he's been alive since 2020, that's pretty good going.
Yeah.
My only patient who I've got as a long-term survivor with this is someone who did get whole abdominal radiation with subdiaphragmatic disease who is alive sort of beyond 5 years post-treatment. So although there are rare cases, they do exist for patients who potentially have very aggressive upfront treatment, but is suffering all the complications of long-term sort of radiation and other bits. So it's a selective tool that you should use in very limited senses, but there are occasional cases of long-term survivors.
I know the Memorial Sloan Kettering series had patients with metastatic disease at diagnosis. I think it's quite hard to justify giving whole abdominal radiotherapy in the setting of metastatic disease. I mean, it's patient selection is going to be the key. I guess it's someone with metastatic disease and responded really well to chemotherapy with no good response on PET and gone through the abdominal surgery, high PEC. It's not unreasonable on a case-by-case series. Okay. Sounds like it's a fairly rare indication for radiotherapy, isn't it, David? Yeah.
Yeah, absolutely.
Yeah. Okay. Good.
Yeah.
Any other questions on this topic at all? I mean, in terms of looking at the Australian, New Zealand experience, I think the number of cases is probably just too small for us to try to pull our cases together and analyze it, isn't it? So, few patients in the last few years. Okay. All right, we might just move on to the next presentation now. So,
Hey, no, you able to introduce yourself?
Yes, I'm just trying to share my slides. Give me 1 second.
Yep, that's good.
Yeah. Can you guys see my slides now?
Yes.
Yeah, okay. So hi everyone, I'm Sakinah. I'm the Med-Onc Fellow here at the PA. So today I'll present the phase 2 trial that was published last month on doxorubicin with zalifrelimab, which is an anti-CTLA-4 antibody, with balstilimab, which is an anti-PD-1 antibody in advanced or metastatic soft tissue sarcoma. So this, I think initially was published in abstract form back in 2023. So to start with a bit of a background, so as we know, doxorubicin has been used as our main standard of care of treatment for metastatic unresectable soft tissue sarcoma since the 1970s, with median overall survival of patients usually ranging around 12 to 18 months. And over the last 15 years, we've seen that immunotherapy have obviously changed and improved outcomes for many other solid tumor cancers. But in soft tissue sarcoma, majority of responses are below 20%, especially with single agent immunotherapy. So the investigator had some preclinical studies using murine fibrosarcoma model, which demonstrated suppression of tumor growth and improvement of survival when they combined doxorubicin with anti-PD-1 and anti-CTLA antibodies compared to doxorubicin alone, which resulted in basically increase in infiltration of CD8 tumor infiltrating lymphocytes, remodeling of T cell clonotypes, and increased RNA expression of T cell activation gene signatures. So they have designed this study mainly to assess for outcomes of patient by combining chemo with dual immunotherapy blockade with zalifrelimab and balstilimab for patients with advanced or metastatic soft tissue sarcoma. So they hypothesized that doxorubicin will increase tumor immunogenicity and boost efficacy of immunotherapy in soft tissue sarcoma. And the primary endpoint of this study was 6-month progression-free survival assessed by RECIST. with multiple other secondary endpoints with overall response rate, disease control rate, PFS, duration of response, overall survival, and adverse events. They also look at other exploratory endpoints, particularly assessing changes with treatment within the tumor infiltrating and circulating microenvironment. So all patients in this study had mandatory tumor biopsies performed at baseline, and then during the study at cycle 2, an optional biopsy at the end of the study with extra blood sampling as well, again at baseline, cycle 2, cycle 4, and end of treatment to try and assess this. So this study was an open label, non-randomized study. It was single institution in the US with investigator initiated phase 2 study. They included patients who were 18 years and above with locally advanced or unresectable metastatic soft tissue sarcoma who are appropriate for doxorubicin. And patient must not have received more than 1 line prior systemic therapy with no prior anthracycline or immune checkpoint inhibitors. They recruited patients between February 2020 and December 2022. And the investigators employed the assignment Minimax 2-stage design. And they also included a safety lead-in part of the study as well to assess for toxicities stopping rule within the first 9 weeks of the study. And following enrollment of up to 16 patients in stage 1, they also did an interim analysis to assess for fertility. And just on the right side of the slide, in terms of treatment received in the study, so it was slightly different between stage 1 and stage 2. So for patient enrolled in the stage 1 part of the study, they were received the zalifrelimab and balstilimab initially as in cycle 1 as a priming cycle, and then doxorubicin was added with cycle 2. The investigators also performed another baseline staging scan before cycle 2 of treatment, mainly to address for any risk of pseudoprogression between screening scans and the priming cycle. Basically the CTLA-4 inhibitor was continued on for maximum of 4 infusions. And the PD-1 inhibitor could be continued up to 2 years. In stage 2, they changed the treatment schema with omission of the priming cycle, mainly because they've seen that several patients in stage 1 progressed quite quickly between baseline screening and prior to cycle 2 in the first stage. So basically all patients received 3 lots of treatment with cycle 1, and they also allowed ongoing zalifrelimab beyond 4 doses in stage 2. Both stages, patients received up to 6 doses of doxorubicin, and they also received LIPEC prophylaxis with doxorubicin, which is a cardioprotectant as well. So in terms of patients' characteristics, so median age for this study was 59 years old, slightly more male predominant, and majority of patients had metastatic disease. All patients had ECOG 0 or 1, and again, majority of patients has not received any systemic treatment. About 26% of patients had received first-line gemcitabine and docetaxel prior to this study. So just a breakdown of the sarcoma subtypes included in this study. So majority was liposarcoma and leiomyosarcoma, which makes up 26% each. And they also included 14% of patients with UPS and 11% with angiosarcoma. There were sort of other rare subtype of sarcomas included in the blue as well as listed there. So intimal sarcoma, epithelial sarcoma, so was also included in this study. So in terms of the study enrollment, so they enrolled 35 patients, and unfortunately had to exclude 2 patients for safety due to drug dose non-conforming to protocol. So 1 patient couldn't finish the first infusion due to chest pain, and 2nd patient had underdosed treatment due to urinary weight. And from the 30 patients available for safety, 2 were excluded, so 3 were excluded for efficacy due to withdrawal of consent, and 1 PD. And out of that, 28 patients were available for 6-month PFS as a primary endpoint. So this study, the analysis of the safety lead-in did not show any prohibitive toxicity, so studies continue enrollment. And again, interim analysis at stage 1 did meet the accrual criteria. So they did, they were able to complete enrollment of the 28 patients. But unfortunately, it did not meet their primary endpoint of 6-month PFS. So the rate of 6-month PFS on the study was 46.4% in those 28 patients. This was numerically superior, but not statistically significant from the 6-month PFS of 43.4% for doxorubicin monotrap therapy. The PFS of this study was 25.3 weeks, which is roughly about 6 months. As further results, so in the 30 patients who were available for efficacy, the overall response rate was 33.3%. And 1 patient did have complete response, and this patient had sclerosing epithelioid fibrosarcoma, with 9 patients achieving partial response. And in these 9 patients, 2 patients actually achieved adequate response that enabled consolidation surgery and further long-term disease control. And they did receive further adjuvant PD-1 blockade of the trial. The disease control rate was 80%, which is quite significant, and median duration of response was 38.7 weeks. The median overall survival was roughly about 29 months with a follow-up of 48 months. So I guess this study did note that the responses seen are noted in the subtypes that we historically would not respond to either doxorubicin or immunotherapy. So they did analyze the molecular sequencing that was available in 16 patients out of the 30 patients and the efficacy population. And I guess not surprising, but 14 patients out of the 16 patients had low TMB with MSI stable. And out of that, 6 patients actually did manage to have complete response or partial response to combination treatment. The 2 patients with high TMB in this study, 1 was radiotherapy-associated breast angiosarcoma. The patient only had brief partial response, but progressed quite quickly following that. And then the other patient had soft tissue leiomyosarcoma with, at best, it had stable disease and again progressed prior to 6 months of treatment. The study also reported, I guess, PD-L1 status, but they didn't specify which PD-L1 assay that was used, but the cutoff for positivity was more than 1%. And again, the partial response was seen irrespective of PD-L1 status. So 3 patients with PD-L1 positive and 2 patients with PD-L1 negative disease. So in terms of other results, they did additional post hoc analysis, mainly due to the much lower final 6 months PFS results noted in comparison to the interim analysis for stage 1 patients. So investigators have raised some questions in terms of why this could be the case. So firstly was either the changes that they've made to stage 2 part of the study by omitting the immune checkpoint priming cycle has impacted on the efficacy of combination treatment. They did raise the question that patients receive low-dose dexamethasone when they receive doxorubicin as chemo prevention for nausea vomiting. But again, the dose of dex use was very low, so 4 milligram with day 1. But that could have suppressed the CTLA-4 blockade with the immune checkpoint inhibitors. Again, I'm not too convinced, as we do use a lot of combination chemo immunotherapy in our other tumor streams, and we do use low-dose dexamethasone as well in those settings. I guess the second question that they had was either the patient selection could have impacted on the results. They did note that there were more immune hot sarcomas in stage 1 compared to stage 2. So there were 3 angiosarcoma and 2 patients with UPS in stage 1 compared to stage 2, where the majority of patients had leiomyosarcoma, or clear cell sarcoma, and only 1 angiosarcoma and 1 UPS in that part of the study. So I guess they haven't, there's still analysis ongoing at this stage to assess for tumor infiltrating lymphocytes from stage 1 and stage 2 patients' biopsies to confirm the differences in early T-cell infiltration and activation from either sequential or concurrent immunotherapy with the doxorubicin. And just the table below, so they did do again post-hoc analysis of different outcomes between stage 1 and stage 2 patients, and we can see that the rate of 6-month PFS was higher in stage 1 at 56.2% compared to 33.3% in stage 2. The median PFS and median overall survival are roughly the same in both groups, but again, marked different in the response rate in stage 1 up to 56.2% and only 7% in stage 2, and a higher disease control rate in stage 1 compared to stage 2. So this graph just highlights the difference in overall response rate in those 2 stages. So the left is stage 1. Again, we can see the change in those patients compared to stage 2, where it's only 1 patient really who had a complete response in stage 2 part of the study. So moving on to the safety data, so the most common tumor-related toxicities noted was fatigue, nausea, mucositis, and diarrhea, and majority of grade 3 toxicities. There were about 45% of grade 3 or higher toxicities, and most common hematological toxicities were related to doxorubicin, as we expected. So thrombocytopenia, neutropenia, anemia, and fibrinogen. For immune-mediated toxicities, the common side effects noted skin rashes, dry skin, and hypothyroidism. They had 3 patients who had more severe side effects who needed steroids plus minus infliximab, and majority had colitis, pancreatitis, type 1 diabetes, and thyroiditis. They did explore as well in terms of the outcome of the patient who developed severe toxicities. As we know from other tumor streams, some of these patients may still achieve durable response despite developing severe toxicities. And again, obviously, this is very small numbers, but 2 out of 3 patients managed who developed severe toxicities did achieve partial response in this study. They also found that the combination with doxorubicin did not appear to increase or the frequency or alter the timeline for immune toxicities. And for patients in stage 2, they were 5 patients who received more than 4 infusions of anti-CTLA-4. And again, that did not appear to lead to a high rates of immunotherapy-related adverse events, with only 1 patient out of that 5 who developed late immunotoxicities. So in terms of the limitations of this study, as you know, it's a non-randomized single-arm study, and the results was actually compared to historical doxorubicin outcomes. They did include quite a heterogeneous subtype of soft tissue sarcoma, and there was that variation in treatment administration in stage 1 and stage 2 with the priming of immune therapy. So unfortunately, this was a negative study as it did not meet its primary endpoint. So there was no significant improvement of 6-month PFS, despite the favorable overall response rate of 33%. But they did note that there was treatment responses noted in otherwise these immune cold sarcomas. There's also some further exploration in expansion cohort where they're assessing balstilimab with doxorubicin, which is a newer novel CTLA-4 inhibitor with better affinity to the Fc gamma receptors. Earlier in the year, there's been early phase data on balstilimab with balstilimab in pre-heavily treated patient, which showed overall response rate of 19%. So this data is still pending. Is just to look at other studies that have tried to assess combination immunotherapy in intracyclic naive soft tissue sarcoma. So there was a phase 1, phase 2 pembro with doxorubicin in 2020. Again, this study was also a negative study as did not meet the pre-specified response rate, but in patients that was included, response rate was 19%. This second study with pembro and doxorubicin did show a better overall response rate of 36.7%, and disease control rate was 80% in that study, which is quite comparable to, I guess, the overall response rate in this study that I've presented. But I guess that, again, just with single agent PD-1 and doxorubicin rather than dual blockade immunotherapy. And a couple of years ago, there was also a published, and this was a published study assessing ipi/nivo with trabectedin, again, as a upfront systemic therapy. We showed overall response rate of 25.3% in that population. So we know that in sarcoma, the pan-tumor biomarker, unfortunately, is not always useful because majority of patients will have low TMB and MMR proficient disease. There's been some biomarkers, I guess, assessed previously, including tier 3 lymphoid structures, which did show improved in overall response rate of 40% with TLS positive patients compared to TLS compared to all comers in the pembro-sac study. And this was pembro in combination with cyclophosphamide. At this point, I think there's still insufficient data to support PD-1 or PD-L1 as a predictive biomarker for immunotherapy for patients with soft tissue sarcoma. Just in summary, so the investigator did conclude that this study did show a durable clinical activity in a subset group of patients by combining doxorubicin with PD-1 and CTLA-4 blockade. I guess the toxicities were expected and pretty well tolerated, and the response was seen irrespective of TMB and microsatellite status or PD-L1 status. I guess in terms of future directions, this study did pose, I guess, further hypothesis generation with options of sequential versus concurrent immunotherapy and chemotherapy in this group of patients. think the study looking at doxorubicin with pembro concurrently versus doxorubicin followed by pembro that we're still waiting for results for. I guess other questions to be answered, the chemotherapy backbone combinations with immunotherapy. This study did note that some patients progress quite quickly after discontinuation of doxorubicin, and other options of, I guess, lower dose metronomic doxorubicin may be more, may be able to be administered longer compared to 3-weekly dosing, which again, I guess, to improve toxicity profile and prolong PFS. And we did see that previously with same study, they used trabectedin, and again, pembrolizumab was used. There's a lot of other studies looking at ID combinations. So we know that there's anti-LAG3, PD-1 combination, especially so that's being trialed as well in Congress study, and results still waiting. And I guess other combination of immune checkpoint with target with TKI as well, which have shown some activities in early phase study. So that's all that I have on this study. Happy to hear any comments or feedback from anyone else.
Great, thank you very much. So open this for discussion. Any comments about combination treatment?
Thanks, Sakinah. Did I just notice that module 1 had better responses than module 2, where they had the lead-in immunotherapy before chemo?
Yes, so definitely was 56% response rate compared to 7%. So for stage 1, and then only 7% in stage 2.
And these other studies that did combination, did they do the same kind of design, or did they do?
So the rest of the study that we have data for so far, so the docs with pembro and ipi/nivo with trabectedin, they all did the treatment concurrently. But there's a study, I think, at the moment looking at dox pembro versus dox followed by pembro and UPS and poorly differentiated soft tissue sarcoma. That results are not out yet.
Okay, that's interesting.
So what was the rationale for the lead-in for the stage 1? Did they talk about?
Do you mean like the safety lead-in, or
yeah, that was done for safety reasons. So
so there was a
it wasn't
safety
for looking at synergy or specific rationale for doing that.
No, it was just more safety to assess for any I guess severe toxicities to stop the trial early. They did then just look at but not for efficacy. They did explore because I guess for the patient in stage 1, the patient had a repeat staging scan pre-cycle 2 as well. So they did assess for patient who responded to see if there's any changes in their tumor size in those period of time between stage 1 and cycle 1 and cycle 2, but they didn't see any different in terms of the tumor change and the overall outcomes following treatment after.
Great, thank you. So any comments from the medical oncologist about combination treatment? Like, are there any studies just looking at the dual immunotherapy, anti-CTLA-4 and anti-PD-1 without chemotherapy agent? I wonder what, we know SARC-028 was just pembro alone for metastatic soft tissue and bone. I think that the response rate, highest one was 28% in the UPS and subgroup.
There are some retrospective data on dual immune checkpoint inhibitors without chemotherapy.
Right.
And I think, again, the response rate is like less than 20%. So I think that's why they try to see, I guess, adding chemotherapy to try and prime the T cells to see if that improved response with immune checkpoint inhibitors.
Right. Okay. Good. Are there any ongoing trial in Australia for patients, I think, for immunotherapy for advanced or metastatic sarcoma? Dr. Badri.
There are lots of trials using novel immunotherapy agents where they have sarcoma cohorts. So, for instance, there are bispecific antibodies targeting PD-1 and something, or CTLA-4 and something else. So, dual, bispecific antibodies targeting multiple immunotherapy checkpoints, and they have sarcoma cohorts. So I've referred a few patients to various trials around Sydney, but I don't have it. There's no results from any of those trials as yet. But is there a trial? I don't know of a trial that is like a sarcoma specific trial where they're trialing a novel immunotherapy. I think from what we've learned over the years is that I think if immunotherapy really, I think there are only a certain number of small, the number of subtypes that are likely to respond is very small. So yes, you can do a trial with, all comers of soft tissue sarcoma. Although it's interesting that in this study, the ones that responded were a little bit different to previous studies, like an endometrial stromal sarcoma and, I can't remember what the other one was now, which is not your typical ones. Like you said,
Yeah, there was
they're
like
usually
MPNST,
MPNST,
which
because
normally don't respond. Yeah,
they're normally,
as well.
as you said,
Yeah.
they're immune cold.
Cool,
So,
yes.
but I think, we are still looking for, there are some, like I said, some trials using novel immunotherapies with sarcoma cohorts, but we don't have data on results yet.
And I think it's always hard to perform those studies in sarcoma, given the rarity of the cancers, to try and recruit patients in, which I think that's always a bit of a barrier for us, I think.
Are there any immunogenic subtype of soft tissue sarcoma you really feel that should be given immunotherapy upfront instead of chemotherapy for metastatic disease, like the angio, the alveolar soft type?
Yeah, alveolar soft part, yeah, angiosarcomas.
Yeah, so Angela, I was just going to make a comment that, it's a bit disappointing to see sort of these trials not showing us any real signal in any particular type, but it's so hard to interpret, right, when there are so many, different subtypes all put together. And I guess all those, traditional ones where we go by with our TMBs and other things, they're not really helpful at all. So I don't think that usually guides me in making a point about who are the ones that I may refer for clinical trial options and things. But even those trial options are not very, accessible for a lot of our sarcoma patients. So only for those with like metastatic angiosarcoma or metastatic UPS, sometimes we may try to consider immunotherapy relatively in the earlier setting, because obviously going by or learning from other tumor streams that it's best to use it earlier rather than in the later line. So they are the sort of the code we may consider. But the other comment I wanted to make is, like how there are the sarcoma immune classes that they are sort of reporting out as a possible biomarker, looking at the tumor microenvironment, those signatures and things, because that looks like quite a promising thing to, get tested. So I'm hoping that maybe in the future that can be something that can guide us. Who are the patients that we could consider immunotherapy early on?
Right. Okay. Good. Any other final remarks or comments on the topic? No? All good. So thank you for the presenting, the two presenters. Really good topics, and thanks for everyone chipping in for the discussion. Now, our next journal club is on the 20th of August, and the Adelaide team will be presenting. So I will close the meeting now. So everyone have a good evening. Thank you.